Okay, so dear students, good morning. So from today onwards, we are starting live online courses in different medical subjects. So today is the day for internal medicine. The first topic for us is chronic renal failure, which is a very important topic from the exam point of view as well as clinical point of view. So I want you to listen very carefully. Now, let's start with the definition. Chronic renal failure is irreversible deterioration in renal function caused by multiple etiology, which results in severe decrease of nephron number and function, frequently leading to ESRD. Now, what do you mean by that? Just like cirrhosis of the liver is the end stage liver disease, chronic renal failure is end stage kidney disease. So in this condition, there is irreversible damage already happened to the kidney function. Okay, and this occurs because of multiple etiology, which results in severe decrease of nephron number because those nephron are the working unit in kidney, and that leads to end stage renal disease. Now, according to National Kidney Foundation, it defines chronic kidney disease as either kidney damage or a decreased kidney glomerular filtration rate of less than 60 ml per minute per 1.73 meter square for 3 or more months. So, National Kidney Foundation has its own definition for chronic renal failure, and it says, okay, when GFR becomes less than 60 ml per minute per 1.73 meter square. This is according to the body surface area. Now we all know it is normal GFR. It is around 120 ml per minute. So if that normal GFR falls below 60 ml per minute per meter square for 3 or 4 months, then it is called chronic renal failure. Now, another very important term is ESRD or end stage renal disease. It represents a clinical state or a condition in which there is irreversible loss of renal function, which leads to permanent need of renal replacement therapy. And they are done in two ways, either dialysis, that is regular dialysis, or kidney transplantation. Otherwise, the person will die because of life-threatening uremia. So ESRD is a end-stage renal disease. That means without renal replacement therapy, the person is going to die. Okay, and this condition is defined as when GFR is less than 15 ml per minute, 15 ml per minute. Now, another part of this topic is causes of chronic renal failure. Now, the causes are so many, so varied. Okay, so think about any chronic condition of the kidney, and you are right, that can cause chronic renal failure, like congenital and inherited disease, which may be there from the time of birth or may manifest a little bit later, like polycystic kidney disease, adult and infantile form. Adult polycystic kidney disease is a very common disease which occurs in 4th or 5th decade of life, but infantile forms occur quite early, and many of these babies they die before there is 2 to 3 years of age. Medullary cystic disease, okay, there is a lot of cyst formation in the medulla. Tuberous sclerosis, autosomal dominant condition where central nervous system and multiple other organs are also affected. Alport syndrome, this is a hereditary nephritis where sensory neural hearing loss and glomerulonephritis are quite common. Apart from them, the second important diseases are glomerular conditions, and we divide them roughly into primary glomerulonephritis and secondary glomerular diseases or secondary glomerular nephritis. Now, they include focal segmental glomerulosclerosis. There are so many primary glomerulonephritis actually, like minimal change disease, okay, membranoproliferative glomerulonephritis, rapidly proliferative glomerulonephritis, okay, then membranous glomerulonephritis, but many of them they don't lead chronic renal failure. One of the most common one is focal segmental glomerulosclerosis. Secondary glomerular disorders are SLE and polyangiitis. These are the example of connective tissue disorder. Vaginal granulomatosis, another connective tissue disorder which mainly damages kidney, lung, and upper airway. Amyloidosis, because of the deposition of amyloid protein in the kidney. Diabetic glomerulosclerosis, complication of diabetes mellitus in the kidney, also known as diabetic nephropathy, accelerated hypertension, hemolytic uremic syndrome. You all know HUS. There are triad of the clinical feature. One is hemolytic anemia, okay? Second thrombocytopenia, and third is renal failure. Now another is a tubulointerstitial disease. Now this tubulointerstitial disease means in between the nephron there are some empty space, okay? So those are affected now. The disease which affects those areas, like some of the drug allergy or drug reaction, okay, or some of the adverse effect of the drug can lead to tubulointerstitial nephritis. Important one are analgesic. We call them analgesic nephropathy. Reflux nephropathy because of VUR, vesico-ureteral reflux. Okay, it is associated with chronic urinary tract infection or chronic pyelonephritis. Tuberculosis, nephrocalcinosis. Okay, some deposition in the kidney, and this is one of the example of renal stone. You can just understand it like this way also. This is the stone formation in the kidney. And multiple myeloma, plasma cell malignancy, which is secreting abnormal protein, and these proteins are getting filtered from the glomeruli and then deposited there, okay, or it can be deposited in some other way as well. Now vascular disease, hypertensive nephrosclerosis is hypertensive nephropathy, renovascular disease, renal artery stenosis, and small and medium sized vessel vasculitis, other type of vasculitis. And the last one is urinary tract obstruction. It has to be a chronic one. The acute urinary tract obstruction doesn't cause chronic renal failure, like renal calculi or ureteric calculi, especially if they block bladder area. Okay, this is very important one. If bladder is blocked, then both ureter would be affected, then both kidneys would be affected. It can easily lead to chronic renal failure. Apart from that, if one ureter is blocked, then it doesn't lead to chronic renal failure that easily. Prostatic disease in male, same type of explanation I can give, just like a bladder stone. Pelvic tumors, more common in female. Retroperitoneal fibrosis is an idiopathic situation usually. And schistosomiasis, like schistosoma hematobium, it can also cause urinary tract obstruction and can lead to chronic renal failure. Now, let's talk about what are the commonest cause of CRF among all from that big list. Now, if you analyze this table, you can clearly see diabetes is one of the very common cause of CRF these days, or end-stage renal disease. So almost 20 to 40% cases of end-stage renal disease are caused by diabetes mellitus. After that, glomerular disease and hypertensive kidney disease, okay, 10 to 20% and 5 to 25%. Then congenital and inherited 5%, renal artery stenosis around 5%, interstitial disease 5 to 15, then other systemic inflammatory disorders like SLE and vasculitis 5%, and then unknown means which are not classified here around 5 to 20%. So this table tells us the commonest cause of CRF these days are diabetes, hypertension, and chronic glomerulonephritis. Okay. Genesis of CRF. What is really happening inside the kidney? Let's talk a little bit about that. Now, nephrons number are getting less in case of chronic renal failure. They are getting damaged, but the remaining nephron will do more job than necessary. They will undergo hypertrophy, and they will do more job, which is known as hyperfiltration. The one small point I like to highlight here: if those remaining nephrons are filtering a lot of proteins, they will develop sclerosis. Okay, they will develop fibrosis, and that glomerulosclerosis is one of the main mechanism for chronic renal failure development. But when you examine the kidney function test in this patient, kidney function test means urea and creatinine, if kidneys are not damaged more than 50%, okay, then there will be no change in blood urea and serum creatinine. So probably the early cases are difficult to diagnose. Now there is one term which is known as acute on chronic renal failure. The person may be having already low GFR. Now normal GFR is 120 ml per minute. If it is dropping less than 90, then we label that as a chronic renal failure has started. It has got different stages. Okay, we'll talk a bit later. But suddenly, because of some precipitating factor, the chronic renal failure will behave as acute renal failure. So this is known as acute on chronic renal failure. So you need to know what are those precipitating factors, and those are dehydration or hypovolemia. Okay, every student can answer what are the cause of dehydration or hypovolemia. Let's not go there now. Even increased fluid in the body, hypervolemia, can damage the kidney because of raising blood pressure probably. Radio contrast administration, okay, like iodinated dye, nephrotoxic drug, analgesics, you can take those name, or some of other nephrotoxic drug. One of the important drug is amphotericin B. This is a highly nephrotoxic one. Infections in the body or in the kidney, and uncontrolled hypertension. All of these can lead to acute renal failure if the patient is already having chronic one. So this is called acute and chronic renal failure. Now, how the patient presents, isn't it? Let's talk about that. In the beginning, the patient may be asymptomatic. There are no signs and symptoms. But when we check urea and creatinine level in the patient, they may be altered or they may be already high. So this is called asymptomatic serum biochemical abnormality. Another one is asymptomatic proteinuria or hematuria. This may also be there. The patient doesn't have sign symptom, but he's already passing proteins or blood in the urine. Hypertension, very, very important finding. Without hypertension, I can never diagnose chronic renal failure. Edema, because of loss of protein, there will be decreased oncotic pressure, and edema is quite common there. Symptomatic primary disease, symptomatic uremia, and complications of chronic renal failure. We'll discuss all these in today's class many times. Okay, this is how CRF may present. Now, these stages I was talking from the very beginning. Please see there. Look at these stages. I'm sure all of you can see it, right? So please have a look there. And I'll check, maybe some of the students have joined later on, maybe they are requesting it. Let me quickly check here. Please have a look there, please. One small request to you, okay? After after 40 minutes, we should take a break of about 10 to 15 minutes, okay? So please remind me. Yeah.
Okay, sir.
Yeah, Daniel is coming now. Very good.
I am there from start, sir.
Good, Daniel. Very good. Yeah, we thought you are still sleeping. Just joking, okay? No problem. Daniel, one work I'll give to you. Can we add like whole batch in the beginning? Can we do that? And if a student join later on, they can simply log in and they can see this. Can we do that?
Sir, we just can do that. We can send the link and they can add by themselves, but we can't add by.
Oh, okay.
Because they are not online. All.
Okay, got it. Okay, fine, no problem. So whoever comes here, they can click on that link and they will be joined. Fine, that's easy. Yeah.
Yes, sir.
Okay, then let's talk about these stages. See here, it depends on the GFR. Now, normal GFR is 120 ml per minute. So, from 120 till 90, the GFR is already decreased than the normal, but we don't call that as a chronic renal failure. Okay. Now, it is very early stage actually, and in this stage, see there, no clinical features would be there. If you measure urea and creatinine, they are normal. So we consider this as a very mild renal impairment. But after GFR, it starts to fall less than 90, then signs and symptoms will appear. So this is mild now, 60 to 89 GFR, that is ml per minute. Okay, still the clinical features are not that much. Moderate, now GFR is between 30 to 59. More clinical feature will start. Anemia is already started here along with the bone disease. Severe chronic renal failure, the GFR is very low now, between 29 to 50. And then end stage renal disease. In the beginning, I clearly talked about this. When GFR falls less than 15 ml per minute, the life will be difficult without dialysis or renal transplantation. So, in the exam, your examiner may simply ask you, what is ESRD or what is end stage renal disease? So, remember this point from this table. Okay, this is important one. Now, we are entering into the main part of this topic. What are the main consequences of chronic renal failure? What is really happening inside the body? Because of decreased excretion, because kidneys are damaged, that is the main function of the kidney, excretion of waste product. Okay, there will be deposition of uremic toxins in the body, which will lead to uremia. We call that uremia or uremic syndrome. Many organs in our body would be damaged because of uremic toxins. 2 or 3 important organs I like to take here as an example. One is brain. We call that uremic encephalopathy. Another is heart. Okay, heart is also damaged by uremia. That is uremic pericarditis, one of the important conditions which we have listed before in pericarditis topic. And another is gastritis, uremic gastritis. It can lead to upper GI bleeding or hemorrhage also. So few of the example. Salt and water retention lead to volume overload, and this volume overload can lead to hypertension. Okay, hypertension. Phosphate cannot be excreted. This is called hyperphosphatemia. Hyperphosphatemia. Now, no need to explain this, but this is very important explanation which will be asked to the student during Viva exam or any other exams. What happens when phosphate is increased? What happens to the calcium level? It will go down, isn't it? Now, because of hypocalcemia, the parathyroid gland would be stimulated. The parathyroid gland thinks that we need to increase the calcium level by secreting more hormone. Now, this condition is called secondary hyperparathyroidism. Secondary hyperparathyroidism. Okay, don't forget the explanation. Later on, also in the same topic, I have included one slide which is discussing that. Now, acid is not excreted, leading to acidosis. This is called metabolic acidosis. Renal failure is one of the cause of metabolic acidosis here. And potassium also cannot be excreted, leading to hyperkalemia. This slide is very important if you want to understand what type of condition is chronic renal failure. Now, our kidney can also synthesize some of the substances, and 2 important substances are erythropoietin and vitamin D. This vitamin D is not synthesized by kidney alone actually.
it is synthesized by skin, then one of the metabolite is synthesized by liver also, but the final activation occurs in the kidney. And when kidney fails, these things cannot happen, resulting in anemia. When erythropoietin deficiency occurs, there will be anemia. And when vitamin D is not active anymore, the person will have osteomalacia and hyperparathyroidism as well. This hyperparathyroidism is caused by hypocalcemia, because vitamin D maintains calcium level in the blood. Now, how to diagnose chronic renal failure? Let's talk about it. The first thing is always history. Don't forget the history. What type of symptoms the patient is having, we should ask. Okay. Then you examine. Okay. Clinical features. In this context, clinical features means physical exam. What examination finding patient is having. Then you order some important tests in the lab, and those tests are some of them are written here, like blood urea and serum creatinine, serum electrolytes, calcium level, phosphate level, and alkaline phosphatase. So all of these has to be ordered. Another is hemoglobin level. What is the hemoglobin level in the patient? Now, what will happen to the hemoglobin level in this case? Every student can answer. It will be low, because anemia is very common in CRF. Urine examination is the must, because this is kidney disease. Without urine test, how can you diagnose kidney disease, isn't it? So urine test is the must, and this urine test will show us probably proteinuria as well as hematuria. And another important point, if you suspect some particular etiology or diagnosis in your mind, just send some tests to confirm those diagnoses, like ANA and anti-dsDNA. These are done for SLE, isn't it? SLE. Serum or urine electrophoresis is done for one important example immediately should come in your mind. That is, any student, why we do serum or urine electrophoresis to diagnose this condition here? You can unmute yourself and answer. This is an open question.
For glomerulonephritis.
Multiple myeloma.
Okay,
Multiple myeloma.
Very good. I'm getting two answers here. One is glomerulonephritis and one is multiple myeloma. But whenever electrophoresis term is mentioned, the examiner wants to hear multiple myeloma. Okay, because in multiple myeloma there is M protein. That M protein in the form of Benz-Jones protein is excreted there. So we want to see that. Another important investigations are radiological imaging. So ultrasonography. Okay, ultrasonography is one of them. You can add CT scan or even MRI according to the necessity. We don't need to order everything, but if we want, we can go for that. Now, after getting all these common concepts, now let's list what are the clinical features of chronic renal failure. First of all, the patient may be asymptomatic. Then in the early cases, patient may complain of vague malaise. Malaise means diffuse pain in the body. Patient may have difficulty to sleep, which is called insomnia. This insomnia is because of uremic toxins, which are damaging the brain. Patient will be very irritable, unable to sleep. There will be loss of appetite. There will be nocturia and polyuria. Nocturia means passage of urine during the night, and polyuria is because of failure of concentrating mechanism in the kidney. Now this is important. Polyuria is a very common feature in CRF. Now you may be confused here, because renal failure, what we understand by that term renal failure, okay, urine must be lesser than the normal. That is very true in case of acute renal failure. In acute renal failure there is oliguria, but in chronic renal failure, because of loss of concentrating capacity of the kidney, polyuria is quite commonly seen. Itching, again because of those toxins. Nausea, vomiting, diarrhea, very non-specific finding. Paresthesia. This paresthesia is a tingling and numbness sensation in the periphery. Now this is again because of neuropathy, and neuropathy is caused by uremic toxin here. Everything is caused by uremic toxin actually. Tetany. Now, tetany is caused by hypocalcemia, and hypocalcemia is a very common feature in CRF. Restless leg syndrome, again because of toxins, as well as neuropathy and bone pain. Okay. Now let me explain why bone pain occurs here. Please listen carefully. Now, when hypocalcemia occurs, which hormone comes out? Yes. When hypocalcemia occurs, which hormone is released?
Parathormone.
Parathyroid hormone. Excellent. Parathyroid hormone or parathormone. Okay, you can answer anyway. Now, what is the function of that parathyroid hormone in the bone? What it is doing to the bone?
Stimulate bone reabsorption.
Very good. It is
Reabsorption.
reabsorbing the bone. It is dissolving the bone. You can answer also like that if you do not know that exact term, or you can also say it is eating the bone away. Now, after that, we can develop different fracture. We can develop different problem in the bone. That is the cause for bone pain. And this bone pain is very, very common in vertebra, on the back, especially the lower back. So this type of patient will complain of low back pain. This is because of hyperparathyroidism again. Other clinical features would be edema in the peripheral part or even pulmonary edema. Peripheral edema is because of more retention of fluid in the body or because of loss of protein. Two important mechanisms we can explain there. And pulmonary edema is mainly because of excessive fluid retention in the body. Excessive fluid retention in the body. That is the meaning. Now, there are lots of symptoms which occurs as a result of anemia. Okay, every student can answer that. The person feel weak. The person feel lethargic. Okay, the person looks pale. There will be tachycardia. There will be palpitation, and in very severe anemia, the person has features of heart failure as well. If the urea concentration is very high, that is more than 50 to 60 millimole per liter, normal. See there, 3.5 to 6.5 is the normal range. It is more than 10 times here in this case, more than 10 times. Then central nervous system may be affected, which may lead to seizure, loss of consciousness, mental slowing, and even twitching of the muscle. It almost looks like a myoclonic seizure. These are very vague features of chronic renal failure. So almost all organs of our body may be affected. Now, after this science, I'll take a break here. Okay, let me do that first. Regarding the physical examination or sign, the person is very short stature. Okay, especially if the child is having chronic renal failure, that child cannot grow properly because there is problem in the calcium level, there is problem in the vitamin D level, so bone growth cannot occur properly, which results in short stature or short height. Pallor because of anemia, increased photosensitive pigmentation, again because of uremic toxin, there is increased photosensitivity reaction, scratch marks, okay, this is because of extensive itching, bruises because of damage of bone marrow by those uremic toxins. Okay. When bone marrow is affected, the bruises can occur because of relation with platelet count. Signs of fluid overload, one of the important signs is pulmonary edema, another is peripheral edema. Pericardial friction rub, very common. This is uremic pericarditis. This is friction rub we can hear. Flow murmur is because of anemia. Okay. These are mainly systolic murmur. Globe and stalking peripheral sensory loss. This is a result of peripheral neuropathy, again because of uremic toxins. So this is globe and stalking. The meaning is the distal part of the limbs are affected. Okay, in the upper limbs, the hands are affected. In the lower limbs, the feet are affected, which is known as globe and stalking type of sensory loss. Now, raised JVP is a feature of hypervolemia. Hypervolemia. Pulsus paradoxus. Now, see there, you have studied pulsus paradoxus somewhere else. You have studied this in cardiac tamponade or pericardial effusion, isn't it? But in this case, also pulsus paradoxus may occur, and this is again because of uremic pericarditis. That uremic pericarditis may lead to deposition, or I should say accumulation of fluid, very rapid accumulation of fluid, which can lead to tamponade, and that tamponade is causing pulsus paradoxus in this case. Now, if somebody asks you what is pulsus paradoxus, the answer is very easy. You have to measure blood pressure, and when systolic blood pressure is decreased by more than 10 millimeter of mercury, when the patient is having deep inspiration, this is called pulsus paradoxus. It also occurs in COPD and bronchial asthma. Now, if I measure respiratory rate, it will be high, again because of pulmonary edema, because lungs are involved here, and because of peripheral neuropathy, there will be absent reflexes and reduced sensation. Okay, all of the things are very easy to explain here. Okay, now let's do one thing. Let's take a break of 10 minutes. Okay, so all of you can come back in 10 minutes. Let's take a break. Otherwise, the classes will be a bit boring. Okay, fine. Yeah. You don't need to log off or something like that. You can simply go somewhere. If you want to stay here and talk among yourself, you are welcome, but only for 10 minutes.
Yes, sir.
Okay.
Promete.
Yala ka sara numali roommate kam na roommate.
Sadama.
Mujib nishta.
Ala amin.
Amina.
Why kana
mal tangkai. Amin خو ډیر خفي یار چې کلاس ته
مفهوم ورله بوخه کنه
Amin
او
يا لك
صدامه کنه ساده څنګه چل یارو
دړو جيبي راکاږي
صدام بکراله
تما خو روزه دا ور اپای سولم یار
کونا ورکو تر جيم
دی
صدامه سمازوکی
امینا
وای
نن درځم ښا
ناراضي کنه ناراضي مړه
نه درځم نن سهیل لقمان راځي
رښتیا وای
قسم دی
یا هم ته درځم
لکه مجيبه
قسم دی
یا هم ته
نه ویل خو دینو اوس به ګورو چې څنګه کوي
بس کله راش بیا ما ته کارو کوي درځم بیا ډېر
او خو به درځو
یو راشه یا خیاطه ته راشي دی خو
ما ورته ویلي
او بالکل تاسو راشي دی خو
ویلو کو دي چې اوس راځي کنه ګورو بنو
بس سویل ملکن راځي
لقمان راځي او سویل ځوان راځي او زه
ښه بس یې اسکله راش بیا ما سره کانټیکټ وکړ ځواب څنګه د پور کې
لکه
امینا
آو بیٹا
چې بزدا لو روغ لاس بدر کې
دا ډېر به درته دی لکه امیر حمزه دا ډېر به
الکه اقبال چرته دی اقبال
خبرې لړګې ده دلته دی
خدا هم
دانیال څنګه
دانیال تعالی غټ په غیرت نه مت دانیال
مجيبه
قربان
دا خو په دړو جيبي راکاږي خو 50 روپے فیسبوک لګوي دا خو مړه تاسو چالو کو 13
لګي
کوټې سر ته ختلې سیګنل هم
صدامه
کوټو کې منډې ماما
صدامه دی خوراشي زمونږ سیر ته وای فای یې کې وتا
ایستا امینا ترجمه ها ترجمه
راشه کنه زه خو ستا انتظار کوم خو ته نه راځې
وائی فائی فری ده کنه
ها بالکل فری دی کور کې مې لګولې دی په سپیډ کوی
واغه
نوازه
امینا
وایا
واغه مخامخ کور والا څنګه دي
دې غر کا غر شي
امینا
لکه اصل غلی شي چې جنګیا په خبرې وکي اسمه ما دې جنګیا
صدام ډیر زیات وچه
ډیر زیات دی خو ډیر موچ صدامو
صدام ډیر زیات وچه
ویډیو کا
صدام سکونی دی مړه
ویډیو کال کې راشي کنه
لکه صدامه
صدامه چرنګه کاوس کې
ویډیو
چفته
صدامه غي دي تپوس کې ای
ویډیو کې راشي ویډیو کې کال کې راشي کنه ته نه
ویډیو نه کوم
ویډیو آن کړه ویډیو کې راشه
صدامه هغه کپڑے مې نه چوری
خوب کی
امینا
زه خو بربند پروتي ما
کپڑے مې نه چوری ظالم اوسې کرا
صدامه څنګه مړه
موږ خپل کټ کې پراتی ورته
مام
یالا کسوګرانه ریکارډینګونه کې په شرمونو به شرمېږو
دا غوال دې ریکارډ شو خبرې وکړي دا کوم خبرې وکړي کوم ویډیو دا ریکارډ شو یار
کاشي پسم د بریک
صدامه
او
دې کله ختم شي کله بیا دا ویډیو کال کوم ښا
او کنه دا راش
صدام د پرسنل کې وکړه صدام د پرسنل کې وکړه
زلګه ګیار وړم
ویډیو خبره اوره
رومیټو وایا
امین له ودا کې ښا
او پوښوا
لکه صدامه
یا صدام کو چې ویډیو ان کې پنهرا
صدام غني کیا یې تری چې پخې چې موبایل یې سي هداله کې جنګو
صدامه لگا
صدام تپوس کې صدام تپوس کې
لګانو
وایا کاشفا
سیبا زما یار لک ټماټر راړم ټماټر ختم دي
صدام گیا روڑی تو
کاشفا کاشفا
جی جی
یاره مورا ته وی لک بار نه صرف روړه دکان نه یاره زرا ځما
تو خپل باندې صرفې
الګا هغه سیف نه ښکاري سیف
په موبایل یې ته دی
hey guys where is the guys where is the
دانیال مسکړی پروګرام کوي
سیپر بریک څومره دی
yes
ها
alhamdulillah
نواز دے
I miss you imam
miss you too bro
علیکم سلامونه
صدامه
او
نواز نواز
رب السلام
علیکم صدامه
او
لکه امام
خدا شکر دی خدا واسم نشدي
دربشم کنه کم ځای کې
دا وا درشه کنه دا غر کا
ډیر
بس ذکر
مصابه
موبایل په سیټو پر راوځو چې مس کلا عشان بسيطة كولا ما تشيس كلام الموبايل مسيرتي أصبر عواصة
ما بدي أخش هذا إمامه
إيه ما خو نم ليكتشر واترم أوريدو ماتي بس
بيرا
سلامة
زان مكمل غيب كله ده خبر تاني لقي
سلامة
أو
जब मुझे कोर्स नेट का ना किसे बाहर बाहर रावत है पटो तो फूले और तरह से
मुझे भी लगती बाहर ना से हमारे पास
أو كمان دلو خدنگام بكي أجل تفسير
سلامة
سيفا والله ها
मुझे वो पटो के जा सरा रास्ते
شيخ
أو
سلام السلام عليكم سلام
السلام عليكم اللي جيتها كم يوم يقول السلام عليكم بس
يا اقبال يا اقبالو
سانجا لك تشتوركي
Bonere.
ये जो नए इकरा संगे
لك اغني يا دياري هو اللي
نقول جوري زور تام संगे
أو كنا
तेरी से
इकबाल
पूछ
बोली करेगी कश्मीर इकबाल बोली करेगी
इकबाल तमो को सकी यार मैं सुन भाई तुमरा
कश्मीर तो पूछती होगा
كاشفة السنة كاشفة
इकबाल है
هي ورز دي بس اسکړې وی چې ټا بیا د جواب نه ورکړې
انا पागल باندې مونږ پوره کې ته پټ شوی وي
यार करो ऐसा बरो
ele kata roja بدل اللي يجي باكستان كده
está Pakistan
आओ
está Pakigura
माइक के पकड़
टूल तो सलाम नवाया और इकबाल
صحیح ده
اجري طيب يا شوي
اثر عليك هغه تیر سنډي را سنډي وو
شور
Okay, guys. Hello.
yes sir
Yeah.
hello
Please,
sir
please mute yourself now.
yes sir
Let's
yes
start.
sir back to class
Back to class. Yeah.
okay sir
Okay. Mm. Okay. So listen. So we are talking
Yes, sir.
about clinical features of CRF, and there are many symptoms and signs. So let's go on to the discussion of complications. Many of these things you already know, and I have already explained also. So it will be easy for you now. Why anemia commonly occurs in chronic renal failure? The most important reason is decreased erythropoietin. Because kidneys are badly damaged, erythropoietin is not secreted. So that erythropoietin cannot stimulate bone marrow. Because we need erythropoietin for the synthesis of RBC in bone marrow. Okay, so that is not happening. First point. Second, because of uremic gastritis. Okay, remember, uremic gastritis, there is loss of blood from the stomach. This is one of the cause of upper GI hemorrhage. So loss of blood again resulting in anemia. But this anemia is a different type of anemia. It is iron deficiency anemia. Now, the first anemia caused by erythropoietin deficiency is normocytic normochromic anemia. But anemia because of blood loss is microcytic hypochromic anemia. Another reason is decreased red cell survival, again because of uremic toxin. This is a type of hemolytic anemia now. Another, because of decreased appetite, the person may not take enough iron containing food. So again, dietary deficiency anemia may occur, and absorption of iron is also a problem from the stomach as well as from the duodenum. Stomach plays an important role. Not exactly the absorption occurs from stomach, but it will convert the ferric form into the ferrous form, and then iron can be absorbed. That occurs in the stomach. So that function probably is not proper in this case. Now, because of the severity of anemia, the person may be having different clinical feature. Already talked about that. In severe anemia, there may be heart failure. In mild to moderate anemia, there would be some other features. Now, second important complication is renal osteodystrophy. Now, this is the damage occurring to the bone because of kidney disease. So, renal osteodystrophy. Now, what is exactly happening in the bone and what is the mechanism for that? Let's talk about it. We already discussed this before. This is a skeletal manifestation of chronic renal failure, and the pathology in this case is known as osteitis fibrosa cystica. Osteitis fibrosa cystica. This is a very important term which may be asked in your MCQ exam. Osteitis, inflammation of the bone. Fibrous, the fibrous tissue or fibrosis is going on there, and there are some cystic species inside the bone as well. Now, what is the reason for this? In case of CRF, in the beginning there is hyperphosphatemia. That hyperphosphatemia is causing hypocalcemia, and this hypocalcemia is leading to increased parathyroid hormone release. Now, that parathyroid hormone is acting on the bone. It will lead to increased resorption of the bone by stimulating osteoclastic activity. That resorption of the bone will lead to cystic appearance in radiograph. This whole picture is known as osteitis fibrosa cystica. And another important point, osteomalacia also occur as a result of decreased calcium. Osteomalacia occurring in the adult and rickets occurring in the children because of low calcium level. So this whole picture is known as renal osteodystrophy. This is one of the favorite questions of any examiner when you give exam. Now, another important complication is neuromuscular abnormality. Neuromuscular abnormality. What happens to the nerves, and because of that, what happens to the muscle or muscular system? Because of uremic toxins, the person cannot concentrate properly. There will be drowsiness or even coma. There may be behavioral change, okay, loss of memory and impaired judgment, again because of uremic toxins, their effect on the brain. There may be hiccup. Hiccup is because of involuntary contraction of the diaphragm, and sometimes this hiccup can turn into intractable hiccup, very difficult to control. And one of the medicine we use to control that intractable hiccup. Anybody know the name of that medicine which is used to treat intractable hiccup? Yes? Unmute yourself and answer.
Chlorpromazine, sir.
Very good. Chlorpromazine. Chlorpromazine. Okay, remember the name. Chlorpromazine is actually antipsychotic drug. It is used in the treatment of psychosis, but it is also used in the treatment of intractable hiccup. This may be an important question for you in future exam. Muscle cramp, fasciculation. Fasciculation means twitching of the muscle. Asterexis is known as flapping tremor. Flapping tremor can also occur in chronic renal failure, but important cause is cirrhosis of the liver. We have already done that before. Seizure and coma. All these can happen as a result of neuromuscular abnormality. Peripheral neuropathy. It is again caused by uremic toxins, and because of this, tingling and numbness sensation in the limbs, restless leg syndrome, and even autonomic disturbances can be there. Now, cardiovascular system is also having a lot of problem, and the most important among them is hypertension. Okay, hypertension is a important complication, and I already told you, without hypertension you cannot diagnose chronic renal failure. Okay, it always occurs in the patient. Now, if atherosclerosis is already there, that atherosclerosis will be accelerated as a result of chronic renal failure. Now I can give a lot of explanations here. This atherosclerosis is accelerated because of hypertension itself. Hypertension is important, a risk factor there. Another one, okay, another one is hyperlipidemia. Now, just think about what is the relation of hyperlipidemia and CRF. Okay. Now, I'll give you a clue here. In nephrotic syndrome, out of the 4 important points, one point is hyperlipidemia, isn't it? Now,
Yes, sir.
that hyperlipidemia is caused by increased synthesis of lipoproteins by the liver. But why liver is doing that? Because of decreased protein, because protein is getting excreted. The same mechanism I can explain here also. In chronic renal failure, there is proteinuria. Because of proteinuria, there is decreased amount of protein, hypoalbuminemia. And because of hypoalbuminemia, there is stimulation of increased lipoprotein synthesis. This results in hyperlipidemia. So now we have got 2 factors, hypertension and hyperlipidemia. So atherosclerosis is accelerated in CRF. Another is pericarditis, we already discussed before. Now, another complication is metabolic acidosis. Now, this metabolic acidosis is mainly caused by impaired secretion or excretion of hydrogen ion and loss of bicarbonate in the urine. So, in metabolic acidosis, HCO3 is reduced, bicarbonate is lesser than normal. Acceleration of bone disease means dissolving of the bone is much more common in acidotic condition. And what treatment can we do to control this acidosis? Anyone? Is there any treatment of acidosis?
Sir, we can treat the renal disease if any cause.
Okay. Any other? Any other? Any other student?
Sir, we can give sodium bicarbonate.
Give bicarbonate, sir.
Very good. Yes. Okay, good. So I already got those 2 answers. Very nice. One is treat the disease which is causing it. Okay, that is renal disease if possible. And second is give sodium bicarbonate from outside. That sodium bicarbonate will decrease the acid level. Now, infection is very common. Infection because those proteins, when those proteins are lost in the urine, some of those proteins are immunoglobulin as well. So infection is quite common in CRF, just like in nephrotic syndrome. Bleeding. Bleeding occurs because of platelet disorders. Now, platelet, there are 2 types of disorder here. One is called qualitative defect, another is called quantitative defect. Qualitative defect is occurring because of uremic toxins. Those platelets cannot function properly. And quantitative defect also occurs because of bone marrow suppression. You can answer in both ways. In GI tract, there is anorexia, nausea, vomiting, very non-specific feature. There is uremic gastritis, which can result in peptic ulcer disease. And that peptic ulcer disease can bleed, resulting in upper GI bleeding. And itching or pruritus is also very common there. Okay, so these are some of the complications of chronic renal failure. Now, let's differentiate between acute and chronic renal failure. Now, see that. Okay, I'll give you a bit of time here. Okay, 1 minute time, just like we do in the class, so everybody can see that screen very clearly, isn't it? Just have a look there, please. Is it okay?
Yes.
Okay. Now see that there is certain differences between acute and chronic renal failure. One is a long history, another is short history. In acute renal failure, usually there is no anemia. The hemoglobin concentration is normal. Even if there is anemia, that is called dilutional anemia. This is not very serious at all. But in chronic renal failure, anemia is always there. It is always there. If you compare the renal size, in acute renal failure, the kidney size are normal. In chronic, they are reduced, they are shrunken, they are decreased in size. Renal osteodystrophy is only seen in chronic renal failure. Peripheral neuropathy is seen in chronic renal failure, and serum creatinine concentration is increased in both conditions. But in acute renal failure, after dialysis therapy, the creatinine level will come back to the normal. But in chronic renal failure, it is always high. So these are some of the important differences. Now the final part is the management. Okay, this is a extensive discussion. Okay, probably I don't need to explain everything here in the class, but the concept I'll try to give you. And if you get the concept, you can do this on your own. See that this is a huge topic. This is a very important clinical manifestation. So it can affect almost whole body. So the management has many headings. First is correction of reversible factor. Second, if there is hypertension, control the blood pressure, decrease it. Third, restrict protein in the diet, because that proteinuria is causing nephrosclerosis, and that nephrosclerosis is one of the main pathogenesis of CRF. Treatment of hyperlipidemia, okay, by using statin. Statin are the drug which we give for the treatment of hyperlipidemia, like atorvastatin is one of the important drugs. Electrolyte and fluid balance needs to be managed properly. Okay, electrolyte and fluid balance. Now, electrolyte hyperkalemia is a common feature of chronic renal failure. So we need to bring that potassium back towards the normal. And there are so many drugs. We have already done that before. Treatment of anemia. Now, in this case, maybe we can give erythropoietin from outside. Okay, if the person is having iron deficiency anemia, you confirm it first and then treat with iron therapy. Renal osteodystrophy is treated by maintaining the calcium and phosphate balance. Bisphosphonate are one of the important drugs which we can use in this case. And finally, the most important treatment actually is renal replacement therapy, especially in case of ESRD. That is the only therapy which is left behind. And renal replacement therapy means kidney transplantation as well as dialysis. Okay, now I can quickly go through the remaining slide because you already got the concept. Now, see that correction of reversible factor means if there is any nephrotoxic drug, stop them. If patient is having heart failure, treat the heart failure. If the patient is having dehydration, go for the treatment of dehydration. If the patient is having urinary obstruction, go for the surgical treatment of that. And if the patient is having any infection like UTI, give antibiotic for the treatment, because these are called precipitating factor which are converting the chronic renal failure into the acute one. Now, blood pressure should be controlled, and many students know which antihypertensive drug we use in this case. Okay, the name is written there. Okay, multiple drug may be tried, but ACE inhibitors are the most important one. Now, why ACE inhibitor in this case? Why not others?
Because it decreases the proteinuria also.
Potassium level.
Very good. So absolutely, that point is important, because there are so many other drugs which decrease the blood pressure. But why ACE inhibitor is preferred in this case? Because it has one added advantage, that is, it is decreasing proteinuria. It is decreasing proteinuria. That is a special advantage of ACE inhibitor. Never forget this. And that is the target blood pressure. It should be less than 130/80. Now, protein should be restricted in diet, but at the same time, too much protein restriction is also not good because the person needs protein for the repair.
Excuse me, sir.
Yes, yes, yeah.
Sir, I have one question, sir.
Sure, sure.
Sir, previously, sir, you told, sir, that in chronic renal failure there is a hyperkalemia. So, sir, SE inhibitors also cause hyperkalemia, sir. So it worsen the condition. So, sir,
Yeah,
why we use?
Yeah, that is a very, very good question you have asked. Okay, excellent. Now, see, listen it carefully. It depends on the potassium level. Okay, if potassium level is very high, if potassium level is very high, which is causing ECG abnormality already, you don't give SE inhibitor to treat hypertension in that case. It may be harmful.
Yes,
okay, but if
yes,
potassium level is not that very high, if there are no ECG abnormality, even if potassium level is high, then I can use SE inhibitor in that case. So it is always a bit of a balancing thing.
Okay, thank you.
Very good. Now, restriction of protein, I'm telling we need protein as well. Protein is important for the repair, and especially in children, we need protein for the growth. So the daily protein intake should not exceed more than 0.6 gram per kg per day in case of severe chronic renal failure. Hyperlipidemia is treated by statin, okay, and that statin, any example teacher can ask you. You can say simvastatin, isn't it? Atorvastatin, like that, very commonly used drug. Electrolytes and fluid balance. If the patient is oliguric, you restrict the fluid, don't give fluid from outside. But many of the patients in chronic renal failure are polyuric, so give enough amount of fluid because they are excreting more fluid from the body through urine. So good amount of fluid may be necessary. It also depends whether the patient is having oliguria or polyuria. So don't generalize, okay? Your answer should be accordingly, exactly like this. If patient is having oliguria, restrict the fluid. If patient is having polyuria, give enough amount of fluid. And one more thing, patient is usually having hyperkalemia, so restrict potassium containing preparation and fruit because they are very rich source of potassium. Now, anemia treatment is mainly done by erythropoietin. I already talked about this, erythropoietin. Then if iron deficiency is there, you give iron. And if very, very low hemoglobin level is there, we can give blood transfusion as well. That is usually given if hemoglobin is less than 7. Okay? Hemoglobin less than 7 is called severe anemia. So maybe we can try blood transfusion. Now, renal osteodystrophy, isn't it? Renal osteodystrophy is treated by first you need to know what is causing it. Then the treatment would be easy for you. Main problem there is hypocalcemia. So you need to supplement calcium, and vitamin D is not also, the active form of vitamin D is not forming in the kidney. So you need to give vitamin D also from outside. This is one of the main therapy. Okay, and to control that hyperphosphatemia, you have to give phosphate binding agent like calcium carbonate or something known as bisphosphonate, or even low intake of egg, cheese, and milk because there is more amount of phosphate in them. But again, don't generalize the thing. Okay, it really depends what patient need. A patient needs these proteins as well. So we balance the thing. If very high level of phosphate, then probably restrict them for certain duration. Prognosis of chronic renal failure, this is a irreversible damage to the kidney. Now see there. So after renal replacement therapy, survival is approximately 80% for 5 years. So after renal transplantation, the prognosis is very good. Renal replacement therapy, the prognosis is good, but still the patient needs to take these medicines for a long time, those powerful immunosuppressive drug, probably till the patient survive. So this is an important point here. And death usually occur in CRF because of cardiovascular event, and that is myocardial infarction. Straightforward, you can say that. And why myocardial infarction is so common here? Because of atherosclerosis. And there are certain risk factors of atherosclerosis in case of CRF. They are hypertension and hyperlipidemia. Hypertension and hyperlipidemia. Now the final component of this class is renal replacement therapy. There are two ways, dialysis and kidney transplant. Dialysis can be of two types, hemodialysis as well as peritoneal dialysis. But hemodialysis is much more commonly done these days. What are the indications of dialysis? This is the important question. In which case we tell patients you need dialysis therapy. Number one, uremic pericarditis. Probably those toxins are in a high level in the blood. We need to filter them out. Progressive neuropathy, important indication again. Uremic encephalopathy, the same toxins are doing the damage, so we need to remove them from the blood by filtering it by dialysis. Persistent anorexia and nausea, and patient doesn't want to eat anything. Fluid and electrolyte and acid-base disturbance, which you have tried to treat by medical therapy, but that is not doing its job. Medical therapy has failed. You need to go for dialysis. And severe anemia needing repeated blood transfusion, because most of the damage again done by uremic toxins in the bone marrow. So probably dialysis is necessary. Now, which dialysis? It depends. If facilities are available, straightforward answer, you have to go for hemodialysis. But if hemodialysis is not there in that particular hospital, the doctor can do peritoneal dialysis as well. Okay, so this is the answer. Now, peritoneal dialysis is a cumbersome way. It is time consuming process, because we need to put one catheter or one needle, okay, into the anterior-abdominal wall, which should reach the peritoneal cavity. You should put some dialysate. This dialysate means it is a hypertonic fluid. This hypertonic fluid should be injected inside the peritoneal cavity. Then that hypertonic fluid will cause, because of the osmotic effect or because of the diffusion process, the toxins would be drawn into the peritoneal cavity from the blood, and after that we remove that fluid again. So this is called peritoneal dialysis. So it is a time consuming process. So the principle is shown here. The principle is same in hemodialysis and peritoneal dialysis, so you can understand. Okay, in case of peritoneal dialysis, you think this area is a peritoneal cavity. That's it. But in this picture, it is a hemodialysis one. So there is the inflow of the blood. Okay, there is a dialysate. It is a dialysate return. This is the inflow of the dialysate. And see this, when the blood returns back to the patient, it is almost clear of those impurity. It is clear of those toxins. So this is why hemodialysis is a very important part of the management. Now, how many times you need to do hemodialysis in chronic renal failure in 1 week? Is it one time? Is one time enough, or like how many times?
3 times. Sir, we can repeat 2 to 3 times in 1 day.
Okay, in 1 day or 1 week?
1 week. In a week.
1 week, 3. So otherwise, the patient will die, sir.
Okay. Now see there. Okay, different answers are coming. So the concept is important here. If possible, you can do every day. Okay, but think about the practical thing here. Hemodialysis is a costly thing. Many hospitals even do not have those hemodialysis machine in them. Okay, there are many patients in the queue. Many patients are waiting for that. So the optimum level of hemodialysis or optimum time of hemodialysis is at least 3 times in 1 week. At least 3 times in 1 week. But if possible, you can go for every day. Okay. That hemodialysis, how it helps now? It will cause excessive fluid removal from the body. Okay, it will filter out all the toxins from the body, and that's how it helps. And to do hemodialysis, the doctor or the nurse need to get the vascular access first, and then they can go for it. And that vascular access is actually a fistula which is formed in the forearm, and that fistula, we do not destroy that fistula, we do not disturb that fistula. It is kept there because patient is keep on going to the hospital many times, so they can quickly do hemodialysis through this fistula. Certain complications can occur during dialysis, and those are hypotension and muscle cramp because of electrolyte imbalance. Sometimes even infection can occur if the the doctor or the nurse did not take proper care of the patient. Okay, the last slide for today, some point about renal transplantation. We need a donor, and who are the donor? Who are the best donor here? Who can donate kidney? Yes.
Relatives. Siblings.
Relatives.
Siblings.
Very good. Very good. Siblings are the best donor. Excellent. Okay. So, but still, before we take kidney from the sibling, we need to do two important tests. That is ABO and HLA matching. Those should be matched between sibling and the patient. Okay. So donors can be live donor or cadaveric donor. And after renal transplantation, you have to keep on giving immunosuppressive therapy for lifelong. The important drug here is cyclosporine. Don't forget the name. Cyclosporine is a very important drug as an immunosuppressive therapy for lifelong. And some of the complications may happen after renal transplantation. If you do not test HLA or ABO typing, then rejection can occur. Hyperacute rejection can occur, or chronic rejection also can occur later on. Infections can occur because of immunosuppressive therapy, and even malignancy can occur again because of immunosuppressive therapy. Secondary malignancies are quite common in immunosuppressive therapy. Okay.